Good afternoon, esteemed members of the CMT Board and of the Executive Board. My name is Dr. Lisa Yamamoto, and I'm here to discuss strategies to address provider losses in both primary and specialty care and to gain funding and support for recommended strategies to support and retain our remaining healthcare providers effectively. The loss of 17 providers within a single month represents a critical exodus equating to a substantial percentage of a typical primary and specialty care team. This is not a new crisis. This is a repeating one. And in the last 10 years, Cleveland Clinic has suffered 3 massive staffing turnovers where scores of providers left service due to burnout. According to the AMA, the replacement of just one physician costs $500,000 to $1 million, and such data highlights the urgency of addressing the retention immediately. As this is a repeating crisis, let's review the interventions that worked well. Implementation of Ambiance AI scribing, the deployment of the clinical access team, quality recognition in the form of RVUs, and extra PTO times. These really help place a dent on stemming workplace burnout, addressing and recognizing that there is a crisis going on. Were implemented, it still didn't stave off physicians from leaving. Additional measures are needed to address clinician burnout, both in the realm of immediate interventions and long-term strategies. Immediate interventions include staffing support and workload redistribution, and long-term strategies such as redesigning work scheduling templates for clinician resilience versus efficiency models, and providing scheduler training and support with direct clinician communication. Deployment of supplemental staffing such as locums and nurse practitioners and reallocation of non-clinical duties can swiftly alleviate provider burden. Case studies indicate that workload redistribution in targeted departments reduced burnout scores by 15 to 20% within 3 months. Such immediate responses can help stabilize care delivery and prevent further attrition while longer-term strategies take effect. By aligning visit length and scheduling decisions with patient acuity and giving physicians autonomy, we reduce burnout, eliminate wasted non-billable care, improve flow, and protect both quality and revenue. This directly aligns with leadership direction for quality documentation and RVU institution, which was discussed in a meeting on 3/4/2026. The key takeaway is that 40/20 scheduling is financially neutral but operationally safer. Longer visits can produce additional downstream value, like more problems addressed per visit, higher quality coding, reduced message burden later, lower follow-up visits due to unresolved issues, and higher patient satisfaction and retention. Additionally, we can further optimize workflows through tech to improve physician burnout through appropriate telehealth integration. This slide highlights why scheduler training is not just an operational issue, it's a care quality and safety issue. When patients are poorly triaged, they're placed into visits that don't match their acuity, and that puts physicians in an impossible position. Either rush care and miss needs or identify that the patient actually requires a higher level of care, which causes moral distress because providers are unable to meet their core objectives, caring for patients well. And in some cases, it creates dangerous delays for patients who need more urgent evaluation. Investment projections indicate that an initial budget allocation of 5 to 7% of overall operational costs are needed to implement comprehensive burnout mitigation strategies such as additional RVU reward funding, personnel hiring, scheduling, training, and technological upgrades. This is a breakdown for the estimated upfront costs for a total estimated upfront investment of $30,000 to $90,000 for a controlled pilot. To remind, one physician departure often costs $250,000 to $500,000 in recruitment, onboarding, and lost revenue. Return on investment includes measurable retention improvements, enhanced patient satisfaction, and cost avoidance related to reduced turnover and adverse event rates. The urgent crisis of workforce burnout and provider loss significantly threatens care quality and access. Our collective commitment to these solutions is crucial to securing a resilient primary and specialty care workforce for the future. Any questions? Okay, I learned a lot of things during this semester. Really, my whole life is a just generalized crisis. But a couple things that I definitely learned was that, like, really from crisis management and also applying it back to the crises that I've actually lived through, like COVID-19. Um, I was like there front line on that COVID ward, and it was very, very um, interesting how taking this class, I can look back and go, gee whiz, yeah, communication failures are the number one point of breakdown. Um, that basically um, message ownership needs to be explicit, like who owns like internal versus external versus clinical versus it has to be um, really, you have to be very explicit on who does the messaging. And there were also like the impact of um, the internet and access to information and miscommunication has to be really heavily monitored for a facility like, say, like Cleveland Clinic. Um, Definitely, redundancy definitely makes a difference. And I mean, I learned this through ACLS, right? Like build a closed loop communication system where basically the message is sent, received, confirmed, and then acted upon. Um, Definitely structure beats improvisation, because I've done that before. And definitely under pressure, it just um, these crisis environments really need a predefined structure. And this is the problem that I was having with with the last project. That I was like going, oh my God, this is so redundant. This is so redundant. But then understanding kind of like why we needed to do that, that was really kind of crucial. Um, and definitely having a, like, no kidding, instant command system and command chain of command, definitely important. I mean, I should have learned that in the Navy, but I, of course, forgot about that. So, because I'm used to actually jumping chain of command. Yeah, I did that. I'm sorry. I admit that. Um, uh, Definitely. This project helped me kind of like identify some of the things that I had a problem verbalizing when because I'm like seeing all this happening. I can see what the patients are saying and I understand it. They sit there and say, but you do it this way. And it's like, well, I've been given time to. I'm a little special being, and maybe what I'm doing right now, is exemplifies the effectiveness of maybe changing up what is being experienced by the poor primary cares. Um, so, but I'm trying to think of everything else that I learned from crisis management because there was a lot. Again, I think I learned the best when we had those in person, like, the meetings. I wish kind of that we had like these touch points. I mean, we did have tons of touch points and you were very accessible, but I'm kind of like wondering if it would have been more efficient to have like weekly meetings for this. I know it's probably really, really difficult, especially with schedules like mine. Um, yeah, uh, my scheduling is really kind of wackadoo, and now I have to go home and go um, train. That's kind of like fun. But no, I really did learn a heck of a lot, and I read the book, but so fast that I don't think I retained as much as I should have. So, but I think that last project was highly crucial. Um, I didn't have to do too many takes um, um, on the actual presentation, just because I was kind of doing it a little bit on the ad lib part. I was like really talking very, very fast. I know that it was probably going to be like Yamamoto on speed or something like that. But I tried to do my best as best as I possibly could. So, thank you again. Thank you very much for everything that you taught us. This was a really impactful class. I kind of wish I would have had this earlier, because when I was initially going through uh, my start at JHU, I had a lot of I was actually in the middle of um, COVID, and it was just that was a perfect time to really do this kind of analysis, because we were just I could have done this while I was sick in bed with that after getting COVID, in February of 2020. Oh man, it would have helped the organization out so much better. But luckily, we had somebody that went through an MBA program. I think they went through crisis management, but they were also like prior service Army, so it kind of helped. But anyway, thank you so much, and hope everything's going well with you. Please feel free to like send me messages or something like that. I don't know if they're going to close off my Johns Hopkins mailbox, but I can be reached by first initial last name lyamamoto@aol.com. Um, you know, to keep in touch and stuff like that. I'm going to definitely turn this into leadership, just to kind of like see what they say, but because this is like information on the ground type of information. I'm not sure if they're going to like utilize it or whatnot, but I'm hoping that maybe they will. Alrighty, guys. Take care. Bye bye.